so much for the invitation, Professor Rajagopal and Professor Valochar Mahachai, for this prestigious symposium. During next 25 minutes or so, my task is to cover on what are the innovations and best practices in 2023 for hepatology. So here's my disclosure, nothing related to this talk. And during this talk, I'm going to cover on 3 topics. And the summary going to be at the end of each topic. So what we would do for hepatology is to try to generalize the hepatology practice to non-hepatologists in order to practice every day. So the first topic got to be expanding the treatment for chronic hepatitis B. When we look at the WHO goal that set on 2016, they would like to identify at least 90% of the burden in the populations in order to treat 80% of those who are eligible for the treatment. But when we look at the baseline, you see that less than 0.1% had been treated. So it's kind of impossible for achieving the goal by 2030. Now, when we look at the most recent guideline, and this is the guideline from 3 continents, from North American guideline, from European guidelines, and also Asia Pacific guideline. So the requirement for the treatment is going to be 2 components combined. Evidence of high viral load in the patient with non-cirrhotic, at least 2,000 to 20,000 IU of the virus, plus evidence of significant inflammation or fibrosis before you can be eligible for receiving the treatment. Now, if we use these guidelines, there could be 4 different subgroups. So the red one going to be the patients who are eligible for the treatment. But some of the patients with high viral load, but did not meet the criteria for significant fibrosis or inflammation, then I cannot, there's no mouse. Then it's not eligible for the treatment, where the patient with low viral load, so it's not eligible for the treatment. Then when we look at, in reality, this is the large population-based study in the US, accounting for 84,000 cases of chronic hepatitis B patients in the US, recently published this year. Among 100% of the patients with detectable viral load. So if we apply the guideline, this is the ASG guideline, less than 10% going to be eligible. But if we include the patient with greater than 2,000 IU per ml of viral load, that accounts for about a third. So you see, if we stick with the guideline, there could be just a small amount of the patients that have significant viral load that can be eligible for the treatment. Then when we look at those patients who had normal ALT, so-called less than 40 in this study, up to 20% had significant fibrosis, more than F2. Moreover, the patients who were eligible for the treatment, that means they have significant viral load plus significant inflammation or fibrosis, when they were treated, as compared with the patients who are lower viral load or did not have the ASC, ALT or fibrosis meet the guideline, you see that those who had severe disease, when they've been treated, the liver-related mortality is much less as compared with those who did not eligible for the treatment. So this is the problem. Because of the integration of HBDNA to the host genome occurs at early life, and this integration is random, and the integration can result in instability and mutation of the genome, and that will result in inflammation, fibrosis, as well as hepatocellular carcinoma. In this elegant study, when they look at the integrations of the hepatitis B to the genome, you see the upper picture represents placebo as compared with the patient who were treated with tenofovir for 3 years. You see the color is less or lighter in the patient who've been treated. That represent less integrations of hepatitis B to the host genome. So the treatment does some benefit in terms of reductions of integration of hepatitis B to the host genome. And with the availability of the potent NOAC with low cost and safe, low drug resistance, we would like to expand the treatment. The first study early of this year, this is the expert consensus from US and many countries from Asia Pacific countries. What they suggest is if the patient has significant viral load, we talk about non-cirrhotic, have significant viral load that is greater than 2,000. And if they have any evidence of inflammation, fibrosis, or if there is no evidence of inflammation or fibrosis, but age more than 30, they could be eligible for the treatment. So this could be more simple, and this can be eligible for any general practitioners to practice out there. Is kind of more simple, at least to reduce the occurrence of HCC. The most extensive guideline just recently published is the Chinese guideline for the treatment of chronic hepatitis B, where almost everyone got to be eligible for the treatment once they have detectable HBV DNA and age more than 30. In case of that, they do not eligible for other criteria. And we just hope that the launch of new WHO hepatitis B treatment guideline, that's going to be launched probably next month, going to be the same guideline as the Chinese guideline. That means treatment for all is going to be more appropriate in order to eradicate the virus, and in addition to prevention of new infection by vaccination. So let's move to the second topic. So this is going to cover for what should be done after the patient with chronic hepatitis C that has been cured with DAA. We all know that with the current DAA, the success rate of cure is going to be very high. And this is going to be beneficial for the patient in terms of reductions of disease progression and also reductions of liver-related mortality and hepatocellular carcinoma. But degrees of benefit depends on the baseline fibrosis or cirrhosis of the patient before they get cured. So another thing is whether these patients continue to expose with some of the risk factors, for example, alcoholic consumption, fatty liver, and whether the patient achieve SVR. So after achievement of SVR, the FibroScan reduction going to be up to 5 kilopascal, and this continue to reduce even after 1 year of SVR, as well as the portal pressure, a few millimeters reductions of portal pressure. So this you see that the FibroScan that contribute to the fibrosis, and actually most of the predictors I'm going to talk later for the FibroScan, the reliable FibroScan result going to be after achieving SVR, because before achieving SVR during inflammation, the FibroScan can be a little bit higher as compared with after achieving SVR. So the first thing to predict disease progressions after SVR, in the patient where the disease is going to be decompensated before the treatment, the key parameters that you should consider whether to treat or to wait for liver transplantation in a country where liver transplantation is not easily accessible is going to be B3A score. So this score includes 5 parameters: BMI, encephalopathy, ascites, ALT, and albumin. So the good predictors, one aside for 1 point. So if there is no bad predictors, the chance of getting recompensated in the patient with decompensated type 2 B and C and recompensated to be a compensated liver disease going to be very high, up to 75%. So in this particular case, this is going to be applicable for, especially in the hospital that you cannot easily access to liver transplantation. For those with compensated liver disease, the best thing to predict whether the patient will continue decompensated got to include the FibroScan and platelet count. So if the patient has FibroScan after achieving SVR of less than 12 and the platelet count greater than 150,000, this patient can be excluded from surveillance of disease decompensation in terms of portal-related decompensation. And this accounts for about 40% of the whole patient of chronic hepatitis B. On the other hand, in the patient with FibroScan greater than 25 kilopascal, these patients are eligible for initiating non-cardioselective beta blocker in order to prevent first decompensation. Anything in between, we need to follow. Usually, we can follow FibroScan as well as platelet count and to see whether they are eligible for initiating beta blocker. The second thing is whether we should screen for HCC. This is the large VA study in the US. So the patient with baseline cirrhosis, if they have improvement in FIB-4 score, we all know how to calculate FIB-4 score by using AST, ALT, and platelet count. Improvement of FIB-4 score after achieving SVR reduce the occurrence of HCC. And the following 2 slides is going to be some of the risk predictor model that you can calculate from the website. And this model, again, from the VA study in the US, using 13 parameters, you see on the box on your left-hand side. And this can be calculated. You can visit the website at HCC Risk Calculator and just put in all these parameters, and then they can have predictions of the risk of HCC and see whether this patient can be eligible for HCC screening or we can leave him alone. Another simple score, and this done from the UK large cohort study, and it's been validated in many studies recently. So this is AMAP score. There are 5 parameters with age, sex, nothing, it's costless, albumin, bilirubin, and platelet count. And actually, difficult to find the website to calculate. What I can suggest to you is you go to the website of Chinese University of Hong Kong at the bottom of the slide, and they have all of the score for calculation for HCC risk. And then in this particular score, you see that on the table, the green account for low risk, because usually any incident of HCC less than 0.2% a year, that is not eligible for screening, is not cost effective. And this accounts for up to 40% of the patient after the treatment. This is simple and can be done on the daytime clinic. You don't have to use any sophisticated machine. Then if you have FibroScan available, so in a hospital where FibroScan available, FibroScan in combination with albumin or platelet count, that can be very useful in the patient with FibroScan greater than 20 kilopascal or in between 10 to 20 plus albumin less than 4.4. These patients are eligible for screening because the risk is still high. But if the patient has FibroScan after SVR of less than 10 or in between 10 to 20 with albumin of greater than 4.4, the risk is very low. So they are not eligible for the screening. Or you can have two-step model combining FibroScan and FIB4. So if there is discordance between FibroScan and FIB4, better go for FibroScan. So if the FibroScan remains greater than 10, the risk remains high. And this patient eligible for screening. As you can see that even the FIB4 greater than the FIB4 greater than 3.25, but FibroScan less than 10, the risk is very low. The most controversial subject in the recent study got to be whether we should screen the patient with F3. And this recent meta-analysis has shown that this patient group is low in occurrence of HCC. And the recent meta-analysis has shown that the occurrence of HCC in F3 after the treatment is very low. And that result in the recent guideline just updated a few months ago for the American guideline in the patient with F3 fibrosis for hepatitis C after cure did not eligible for screening. So just to summarize, in hepatitis C patients, after the treatment, you can look for the fibrosis stage and other risk factors. And the screening, it depends on whether you go for fibrosis-based or risk-based. So nowadays, it's going to be the combination. So the risk-based, that composed of fibrosis status, also other factors, and these eligible for calculation, the simple tools for calculation that you can find in the website going to be HCC risk calculator and AMAP calculator. My last topic during the next 6 minutes or so got to be assessment of fatty liver disease in clinical practice. We all know fatty liver disease is very common, and this can result in severe and progressive as well as cirrhosis. However, the diagnosis in the past must exclude other possible causes, and also the patient with concomitant alcoholic drinking cannot be diagnosed as non-alcoholic fatty liver disease. So that comes to the conclusion from Asia Pacific Association. We had published the guideline back into 2020 to change the name from non-alcoholic fatty liver disease to metabolic associated fatty fatty liver disease. And this is simple. So any patient with diabetes, they're gonna have the high risk factors for having metabolic associated fatty liver disease. Any patient for having at least 2 metabolic risk factors, as shown here in the middle, this eligible for screenings of non-alcoholic fatty liver disease or metabolic associated fatty liver disease. Any patient with overweight could be eligible. However, this trigger the rumor and discussion among the Western countries, and among during 2 years of discussion, they comes up with a few months ago with the term. They did not want to copy our term, so they used another term instead of MAFO. They used because they just say that fatty is kind of bullying. So they changed fatty to static. So they changed the name from MAFO to muscle. So, so this is the inclusion for European and American guidelines to change the name from non-alcoholic fatty liver disease to muscles. Who should be screened for fatty liver disease? So any patient with diabetes, obesity, and also the patient with presence of at least 2 metabolic factors. And recently, last year and this year, there are 3 guidelines published: AGA guideline, American Association guideline, and also American Association combined with Endocrinology Association guideline. But all of these 3 guidelines are similar. So you look at the patient at risk and then screen with non-invasive test by using FIB-4. If FIB-4 is less than 1.3, you just follow, and then you can repeat FIB-4 calculation maybe every few years. For those with FIB-4 higher than 1.3, especially where the patient with FIB-4 greater than 2.67, you need another tools, for example, FibroScan or ELF score, in order to stratify these patients to be whether significant fibrosis or not significant fibrosis. And if the patient did not have significant fibrosis, you can repeat the assessment every few years. But those with intermediate, you better repeat the assessment every year. For those with the significant fibrosis, these got to be eligible for portal hypertension screening and as well as hepatocellular carcinoma screening. And the management of fatty liver disease, the generic one got to be lifestyle modification, weight loss with implementation. Pharmacologic intervention got to be applicable for the patient with high FIB-4 or high FibroScan, intermediate to high risk, and this is going to be eligible for the treatment. So just to summarize, to approach the patient with non-alcoholic fatty liver disease, so if you look at the patient at risk and assess whether how severe was the fatty liver disease, weight loss reduction as well as lifestyle modification could be implemented in every patient. The drug treatment, especially for the patient with diabetes, you should look for the drug that can have also effect on the diabetic control as well as the fibrosis regression, and also the treatment for cardiovascular risk reduction. One thing that you should also tell the patient, because many of our patients will be afraid of taking statin. The good thing for statin is in the patient with significant fibrosis, statin can reduce portal pressure. So this could not only reduce occurrence of hepatocellular carcinoma, but also portal pressure. So statin is good for the liver. And lastly, if the drug is going to be implemented for general, vitamin E can be used for non-diabetes, and for those with diabetes, if you don't have any new generation of the drug, prednisone can be another alternative. Thank you.